Hello and good evening and welcome to this webinar. So tonight we are going to be talking about diagnostic ultrasound in sports medicine. More specifically, what is the scope of its use from pitch side to the clinic room? So I'm delighted to be joined by Dr. Dan Brooke, who's going to be talking a bit more about his background, but then also going into this. So I've known Dan for a few years and I'm very much looking forward to hearing from him. So Dan, I'll pass over to you shortly. But just in terms of PhysiQuip, so my name's Andy Thomas and I'm the director at PhysiQuip. And we supply technology and education to enhance clinical practice. But one of the main drivers for us is that we want to work with great people, both in terms of the clients that we work with and the educators we use. So I'm particularly happy that we're going to be working with Dan on this evening. So thank you very much for joining us, Dan, and I will now pass over to you.
Pleasure. Thank you for the kind introduction, and good evening, afternoon or morning to everyone, whenever you're listening to it. So yeah, the title is Diagnostic Ultrasound in Sports Medicine, and we're going to talk a bit about the scope of its use from pitch side to the clinic room. So just a quick introduction about myself. I am a consultant in sport and exercise medicine, trained in London. I work primarily for pure sports medicine, working at the Chancery Lane and Bank clinics. I also work as a consultant at the English Institute of English Institute of Sport in Bath, where I work half the time as a sports physician and then the other half as the Chief Medical Officer of skeleton bobsleigh, who you may have seen at the Winter Olympics. Also do a bit of rugby work, including matchday doctor work for Premiership and European Rugby. Previously worked for Ealing Trailfinders and the England's under-20s doctor. Do a bit of hockey work and a few other bits and pieces. For anyone who's interested, my Twitter is @Dan_Brooke, and I'm also available on email, which I'm sure we could give out if anyone is interested. Okay, so it's going to be a relatively short talk this evening because I think it would be nice to have quite a good discussion about this, and I know there are a few questions already. But we're going to talk about what I feel the importance of ultrasound uses in sports medicine, particularly looking at the use of diagnostic ultrasounds, and then talking about the use in pitch side medicine, and then in the clinic, and then do some questions and answers at the end. So, is ultrasound important? Well, yes, I think it is. And we talk about the four cornerstones of medical imaging in the 21st century. They're CT, MRI, X-ray, and ultrasound. And I think ultrasound is becoming more and more important, and it's used in more and more settings. Why is this? Well, it's cheap, it's quick to produce, often portable, and there's minimal, if not zero risk to patients. Can give you quick answers as well. And in the world of sports medicine, that's really key. If you're working with a Premiership football team and a player's got a tight hamstring or a bit of an injury in training, if you can get an ultrasound on them, you can give the manager a pretty good answer pretty quickly, and the rest of the medical team as well. But it's really important to do it proficiently and to have appropriate qualifications. So whether that's doing a postgraduate certification in musculoskeletal ultrasound or a diploma, or even studying up to master level, it's important from a medical legal perspective to have proper qualifications by a robust and properly certified course. And by doing this, you gain a good understanding of the physics, which is important to understand what you're seeing, but also what you're not seeing. And that helps you understand the limitations of ultrasound, which are there and are many. And it's important to know when you can use it, but then when you shouldn't, when you should use other modalities. And why is it important? Well, if you go around most of the top teams, whether that's rugby, Premiership teams, football Premiership teams, international, Olympic clinics and things, most of them have got them. And most sport and exercise medicine consultants can do it. So it's an important part of the diagnostic tool set. What are the pros? Well, as we said, it's quick to do, plug and go, or if it's plugged in already. It's cheap. Once you've bought the machine, it kind of pays for itself in a few scans over a period of time. It's often portable. You can have portable versions and the more hardwired ones. I like to think of it as a laptop or a desktop version. There's no radiation, which obviously there is in X-ray, and particularly in CT. What are the cons? Well, it's very, very user dependent. The most skilled radiologist or MSK sonographer is going to produce an incredible picture and rule out things. Whereas somebody who's just using it for the first time, there's going to be a massive difference. And also it comes with experience about knowing what you've seen and what you can't see, but also for things like lumps and bumps, which are outside of the musculoskeletal skill set and need to be referred on to more appropriate people. Also, the deeper you go, the lower the resolution. So it is not as good at examining deep structures in detail. So things like the hip joints can't get as good detail. And also your larger athletes or larger patients, it's hard to get as much detail. And just generally less detail, less resolution than MRI and CT. Use of diagnostic ultrasound. Well, in my opinion, diagnostic ultrasound is great, but there's no use for therapeutic ultrasound really. Some people might use it in certain settings, but generally there's a move away from that. There are certain circumstances where it might be useful, but not in sports medicine, in my opinion. What can we use it on? Well, we can use it on muscles, tendons, ligaments, and even bone. And that's kind of the general skill set for musculoskeletal or sports medicine ultrasound. And just thinking outside the box as well, it's being used in different modalities of medicine. So in trauma, potentially if you have someone who's trained in emergency medicine, A&E trained, they often do point of care ultrasound training. And that could be used pitch side. If someone's had a big hit, so a rugby player's had a big hit, they've got pain in their left upper quadrant of the abdomen, can have a splenic injury perhaps. Ultrasound could look for some free fluid, which could potentially tell you if they need to get to an A&E setting quickly or otherwise, and generally to scan for things could be used. Echo as well, so echocardiograms. If you've got a cardiologist in your team, maybe your Man Uniteds or your Arsenals, or even some of the NFL teams, they often have every specialty there at the side of the pitch because they can afford it. You can have a cardiologist, so if someone has a bit of chest pain or they've got cardiac issues, you can do a quick ultrasound for echocardiography. Could be an option as well. In terms of pitch side, I think there is limited scope of use, but I think there can be some use for it. Acute injuries, obviously. So if something happens then and there in the match, if you can get a scan on before they get too swollen, too much bleeding, that can be helpful. And these are just cases that I've experienced personally, and I think, could potentially be useful. An Achilles rupture or Achilles injury, you're worried about that. You can stick an ultrasound on. You can even potentially, if you get there quick enough with not too much swelling, you could look at the gap. Generally, the rule is if there's 1 centimeter gap in full dorsiflexion, then you may consider it needs to be operated on. Most professional athletes would probably have surgery anyway. You can get quick answers then. You can also add to your diagnostic set. Gives you a diagnosis of an Achilles rupture or not. Muscle injuries, incredibly common. Someone has an injury, you could get a rough idea whether it's a short, medium, or long term. It's not perfect, but it could be used. Bone as well. I'm going to go through a few examples of this, but there's an argument that it could be used for some bony injuries. I think some of the more superficial bones, radius, maybe your tibia, you can get a good picture of the cortex. Could you find a fracture or a subtle fracture potentially? I think wrist injuries especially, and often now they're used in A&E as well. If somebody has a distal radius fracture, you might do ultrasound to do an ultrasound guided injection of local anesthetic to numb it. It's possible. It's not going to be your thing you rely on entirely, but it's certainly something to consider and have in your back pocket. And again, so wrist injuries, talking about emergency medicine use, the free fluid, which we mentioned, if you're an appropriately skilled and appraised practitioner who does this regularly, you could do it perhaps. Maybe at your big stadiums, Wembley, Old Trafford, Twickenham, where you might have the facilities, and then if you've got a cardiologist as well. So this is an example of an Achilles tendon rupture, and you can see in full dorsiflexion, there's a gap there. That could be found on an acute injury. Calf muscle tear. You can see in the gastrocnemius here, there's a large example of a tear, tennis leg, medial gastroc injury. See the hematoma developing there as well. This is not taken acutely, but just gives an example. Long bone, so you've got the cortex, bright white line, bone is bright, and there, and you can see the disruption. So it shows you a fracture there. That's I think a forearm fracture in a younger patient. And then, and this is a really beautiful picture, which was on Radiopedia. And this shows your scaphoid bone. Obviously, that's an incredibly important diagnosis not to miss. And you can see a crack there in the scaphoid. And this is ultrasound. You're probably going to get an MRI anyway to confirm and to give more information. But that just helps to lower the threshold for moving on to an MRI. You definitely know there's some sort of injury, probably a scaphoid fracture. Get an urgent MRI, get diagnosis and appropriate management. The big caveat, though, for the use in pitch-side medicine is that most injuries, we would say, are often best assessed after about 5 days. Allow the pain, swelling, inflammation to settle. It allows you to examine much better. And if you can examine, you can then correlate with ultrasound findings. Great example of this is with a lateral ankle injury. Often they blow up straight away, huge swelling. You're not going to be able to assess the stability of the ankle, the lateral ligament complex, until maybe 5 days, until things have really settled. But you're also going to struggle to get a good ultrasound picture if there's a massive hematoma there. So unless you get in there straight away before it starts to swell, you're often going to need to wait a few days for it to properly settle. Which brings us on to the clinic. And it's probably where the most useful application of ultrasound is in reality. But you just don't jump into ultrasound, and this is really key. Don't take shortcuts. Take a really good history, have a good examination, maybe special tests, and then use ultrasound. Often we're told the best way to use imaging is to confirm your diagnosis. So if you're able to get a really good examination, so you're examining an ankle, you think there's quite a big anterior jaw, you're expecting to see an injury to the ATFL, maybe CFL. Same with syndesmosis. It then helps guide and focus your ultrasound and helps confirm. You're just adding more information to the picture. One of the best uses is that you get imaging straight away. So quite conveniently placed behind me today in the clinic is an ultrasound. It's a Logic E9, I think. And what's great is that the patient can come in, and the first time they see a practitioner, they've had a history examination and some form of imaging. And often ultrasound is sufficient for a lot of these. You get a one-stop shop, and there's a move in the NHS as well to be doing ultrasound with musculoskeletal sports medicine clinics. The Faculty of Sport and Exercise Medicine has done some incredible work and found that if you have a sports medicine consultant with an ultrasound machine, you have less MRI scans, less follow-ups, and it's more cost-effective. Cost of living crisis, we know that as efficient as you can be is the key. Arguably in clinic as well, that actually a lot of tendons, you can get a more useful clinical information from an ultrasound than an MRI scan. You can check in great detail for example, an Achilles tendon. You can get some good measurements, and you can look deeper as well. So looking at things like Kager's fat pad, or for any plantaris tendon as well as a differential diagnosis. It's also a dynamic test as well. So like we were talking about with the Achilles tendon rupture, you can look at the tendon dynamically, see if there's any potential injury, and also looking for any impingement in certain areas, things like bursitis. I would say, in my experience, the most useful applications of this, and arguably where it's more useful than MRI, is in Achilles tendons, patellar tendons, rotator cuff in the shoulder, and lateral epicondyle, which is obviously a common extensor origin of your extensor tendons. These are common and important injuries, and they are easily added, the clinical picture is easily added to with ultrasound. You can also grade the severity as well. So you come into clinic, you get an idea if you've got a grade 1, 2, or 3, which is obviously a bit of a rough guide that can be beneficial for prognosis. A lot of the time you might get an MRI scan as well, but it certainly limits the number of MRI scans that you're going to need. What's really helpful as well is that, say, if you have an Achilles tendinopathy, considering shockwave, the patient might have seen someone. You can check for partial thickness tears, because that would arguably be a contraindication for doing shockwave. If you can get some sort of quick imaging on, you can find out whether that's relevant for the patient or whether there's a contraindication. You can be confident that you can then go forward for some shockwave. And at Pure Sports Medicine as well, we would tend to get some sort of imaging on a tendon before we do shockwave, because it's best practice. Also, there's an argument for monitoring recovery from injury. So whether that's a muscle tear or Achilles as well, you can get some information from that. But arguably, there's a delay in the radiological finding versus how it is clinically and functionally. And so you have to take it with a pinch of salt. It's not the be all and end all. Okay, so is it useful in sport? Well, there was a paper on the most common football injuries, and this is from the BJSM from 2020. The 4 most common injuries from a large scale study were thigh, knee, ankle, hip, and groin. And arguably all of these can be diagnosed, even on ultrasound, even the knee on ultrasound. If you do a knee ultrasound and you find an effusion, you can't obviously see inside the joint, but it's going to lower your threshold for getting an MRI scan, because it tells you there's probably some sort of intra-articular injury. And what the incidence of the injuries by type of tissue, as well as location, is muscle and tendon, which are obviously, and which is 4.6 per 1,000 hours of exposure, which is considerably the highest, and they're all amenable to ultrasound. Go to rugby as well. Well, the most common rugby injury from 2021, going back a couple of seasons, was head and face. Obviously, concussion is high, but the overall injury burden was knee, and so it's relevant there as well. Ligament strains also very common, muscle and tendon as well. And the number of players who have had an acromioclavicular joint injury in their shoulder is more than most. And so it's very useful for ultrasound application there as well. Going to the Olympics, so a slightly different type of athlete. The injury incidence epidemiology from the 2016 Rio Olympics showed 221 severe injuries, which are described as an absence at least 7 days, of which 29.4% were muscle strains and 25.8% were ligament strains and ruptures, which is the highest. They were the highest 2 types of injury. And in terms of the area, knee, thigh, and ankle were most common. So ultrasound's relevant for here. So again, talking about another use in clinic, well, injections. They're very common. Obviously now with the change in the guidelines from WADA, you have to get a TUE, but steroid injections still very common and very helpful for patients in certain circumstances. The recent paper, which the reference is at the end, has argued that ultrasound-guided injections are superior to landmark-guided. And a lot of sports medicine consultants would agree with this, I believe. Why is this? Well, you can ensure that the exact correct area is targeted. You can also save the images and video, which from a medical legal perspective is important. Patients often get complications, but if you've got evidence that the needle's in exactly the right place and not in another structure, I think that's really helpful. And you have to protect yourself to a degree. And it's helpful to save the images and injections. For a lot of our athletes who are very body conscious. You've got to target exactly the right area. You can't just do a blind injection. Someone might have a bursitis in the rotator cuff, subacromial bursitis. If you target that exact area, that will give you a much better outcome anecdotally than just a rough injection to the area. Same with tendon sheath, hydrodilatation, hydrodissection. It tells you that you're in exactly the right place. And I wonder, medical legally, they may argue if things go wrong, why didn't you do ultrasound guided if it is best practice? There's still an ongoing debate about this, and I saw a really good Twitter thread on this for hip injections. But if you've got it, why not aim for the best practice? I'll do 3 quick case studies from patients that I've had, which I think show the relevance of this. So we have an Olympic athlete, quite sprint-based, has Achilles pain, diagnosed as Achilles tendinopathy, want to know the best treatment. So we do a quick ultrasound in the clinic, which shows, is it in the acute or inflammatory phase, reactive phase, as defined by Jill Cook's tendinopathy continuum. It shows there's no inflammation, so we can more confidently load it as opposed to offload and rest, help speed up the recovery. And that's just a quick summary again of the tendinopathy continuum as proposed by Jill Cook et al. So if it's reactive, you might want to deload. If it's more disrepair or adaptation, then you can confidently load it with things like isometric exercises. Second case study, an athlete represents to clinic 10 days after an initial ankle inversion injury. They've had a second injury and it's increasingly painful and swollen. They've got the World Championships for their sport in 10 days. You need an answer. Are they going to be able to compete? If not, someone else has to be selected. They can't fly out. Ultrasound here shows grade 3 ATFL, grade 2 CFL, and a grade 1A ITFL. They've had a severe injury that was maybe not seen initially or has increased in time. They're probably going to have a few more testing and some physio-based objective testing, but you can pretty confidently make a decision that this athlete is not going to be able to go to the World Championships. That decision's done within 45 minutes. Final case is an under-20s rugby player who's had a bit of thigh pain after a strain. Pretty common, quad strain, rec fem maybe. However, when you see them, when I saw them in the clinic, they had unusually high levels of pain. Quads felt quite swollen and tense, and there was reduced range of hip movement. Ultrasound straight away showed a large collection or probable hematoma deep to the rectus femoris. On further questioning of the athlete, turned out he had done 100 extra box kicks in training on top of the other training, and had felt it but had kind of pushed through. MRI was then done, which confirmed the large collection and had to have an ultrasound guided drainage. But initially you've got a lot more information there, and also it can help reassure in some ways that there's nothing like a compartment syndrome. Okay, so quick summary. Ultrasound has many uses in sports medicine. In the pitch side setting, there's probably limited applications, but there may be some that develop, and we've got to keep an open mind and try and be a bit inventive. Main use though is in the clinic. And in some areas, it's probably equivalent or even better than MRI, depending on the patient and the case. It's quick, it's easy to get hold of and access, and there's no real risk to the patient. Ultrasound guided injections are probably the gold standard, but you have to be aware of the limitations of ultrasound and when to go for further imaging. I have references here as well. If anyone would like afterwards, we can send out. Otherwise, thank you very much, and I look forward to answering some questions.
Dan, thank you very much for that. That was before we go into, we've got some pre-submitted questions. I thought that it was really interesting with the common injuries that you mentioned. And I was speaking to someone from an elite football club recently, last week in fact, and they were saying that they use ultrasound, but maybe they don't use it as much because they like to refer out for more in-depth imaging, because maybe they don't want to pick up too many things. Like, what would your view on that? Can you over image, or is more always better?
Yeah, I think, you can over-image, but it comes with the skill and confidence of the practitioner. And it's about being aware of, don't use the imaging as a fishing expedition. Use it to focus and confirm your diagnosis. And it's just an adjunct. It's a small add-on to your history and obviously your clinical examination. And yeah, if you've got a footballer who's been playing for 15 years, if you scan their ankle, you're going to see all kinds of things. Rugby player shoulder, cervical spine in a prop or a hooker in rugby. You have to be aware to contextualize it. But, I think ultrasound is useful, and it can often reassure if someone's got a bit of a niggly tendon. And but you want to make sure there's not a really raging tendinopathy. And but I think it's having the confidence as a practitioner to know the application of it.
Okay, great. No, that's really helpful. Okay, so first question here. So this is from the person asking. So how do I interpret the ultrasound results in training, and when and how often do I validate my results?
Yeah, and I think this is really key, because there's obviously a patient safety element here, and as part of a general good clinical governance, which is key. And I think you need to do your ultrasound training through a proper course, proper provider. So I did my postgraduate certificate in ultrasound, in musculoskeletal ultrasound, down in Bournemouth at the Anglo-European Chiropractic College, which many sports medicine doctors do. There's also one at East London, which I know is used very well, and at other universities as well. And that's the key. Do a proper course and make sure you have a mentor or supervisor. Because when you're learning, you can't do these things independently or autonomously, because you don't have the skill and the qualification to know what you're seeing. I mean, in theory, if you ultrasounded everything and then got an MRI to correlate, that's one way of doing it. But do a proper course, do the science, to have the skill set, and have a mentor and supervisor who can help basically correlate what you're finding and confirm.
Yeah, and just a follow-on question to that then, because we see an exponential growth of people using diagnostic ultrasound, both in elite sport but also in clinical practice. And mentorship is something which we see is really important, but there's not that many out there, that people do struggle to find them. Have you got any suggestions or advice on how someone may find a mentor?
It's difficult, and it's very area dependent. If you can find a friendly radiologist, that's helpful, or friendly sonographer. A lot of the official courses will help provide you with mentors and supervisors, but it is tricky, and you often have to pay for the privilege of it. So before, if you're thinking of doing some training, getting a machine, try and make sure you have the ability to have someone supervise you who knows what they're doing and can help sign off your 50 scans or 100 scans or whatever you need to do. But it's not always easy, and it's very area dependent as well.
Yeah, that's what we've found as well. Thank you. Okay, next question.
Sorry, the other thing I was going to say is that there are a lot of courses as well. The SMUG group, Sports Medicine Ultrasound group, do some really good courses. But obviously they're 1 or 2 day courses, and you have to follow up that with more skill. But if you can get on some courses as well, the SMUG and other groups do some really good things.
Yeah, I agree. So what are your thoughts on the use of elastography in managing soft tissue injury and as a tool to quantify tissue stiffness prior to reloading?
Yeah, I've spoken to a couple of other sports medicine consultants, and there might be a use for it in the future, but at the moment it's not used clinically that I'm aware of, certainly not with the Olympic athletes that I see. And it may be used in a research basis, but I don't think anything has been used or validated yet, particularly in the elite athletes, so like UTC ultrasound as well. Maybe there's a possibility for research, but it seems to be that your bread and butter musculoskeletal ultrasound helps a lot. But keep eyes peeled and see if some good research comes out. Could potentially be a use in the future. We mentioned before as well how radiologist at the Imperial Hospital Group, Dr. Dimitri Amaris, was looking at elastography instead of compartment pressure testing. I don't know what's come of that recently, but there could be a potential for this, but nothing that I'm aware of yet. Certainly nothing that's been validated and used clinically.
Okay, thank you. So this is a more specific question around which portable unit do you favour and why?
Well, it depends what you have access to. The two of the main ones would be the Logic, which a lot of people use, which has been used for a while, made by GE. Obviously, Physiquip sell the Alpinion systems, which are excellent as well. Often you just need to try them out, find what your budget is, and find what works for you. But I've used the Alpinion in a couple of places, and that's worked really well. Also use Logic as well. There's a few of those around. Will often be key things to think about are reliability, how much it costs, and then also about the aftercare and support from the companies as well who are selling it to you, because sometimes things go wrong, and also it's helpful to have a bit of nuance on the subtle parts of ultrasound.
Okay, I won't add anything to that. I'm obviously impartial in that question as well. So how soon would you rescan the patient following an acute soft tissue injury to check the healing process?
Yeah, I kind of mentioned this a bit before. There is often a radiological delay, and often you wouldn't bother scanning at all. You know, you have a muscle tear, you scan it, and it doesn't look great 4 to 6 weeks down the line. But actually, functionally, it's good, and there's just a delay in what it looks like on the imaging versus how it is in reality. There are certain cases where it could be useful, though, such as if you've got a large hematoma, and particularly if you drain a hematoma, say, in a large calf muscle tear, you then want to see if that's had a reaccumulation, and you could potentially do another ultrasound-guided drainage. But generally, it's not used in the monitoring healing. You're best off examining them, getting some functional and objective testing, because that's probably a lot more helpful. Only further image if you're worried about anything or if there's any setbacks.
Okay, thank you. So can you use diagnostic ultrasound to predict hamstring or other muscle injuries in athletes?
The simple answer, no. If you had a small tear that was there, you could potentially see that and it would become a bigger tear, but then hopefully you would pick that up on their reporting. Injury screening is the panacea of sports medicine in many ways. And there are very few ways of predicting this, whether you're doing objective muscle injury testing, strength testing, things like groin squeeze, Nordics for hamstrings, various dynamometry testing. You can't predict injury, and there's been some great research on this. If someone is injured, you could potentially see that before it becomes a larger injury, but there's no application of this for ultrasound, unfortunately. Maybe if you had a partial tear of an Achilles, you could see that, and that could then become a full tear. But even then, it's not there's not a direct correlation.
Okay, thank you. So when learning to scan, do you recommend trying to concentrate on perfecting, say, one specific joint at a time, or is it more of a global thing that you would recommend? Are there any techniques around that?
Yeah, no, I think it's very global, and the way I was taught the course, which I think is good, is the first module is on science and instrumentation. So you're understanding what you're using, understanding what you see and what you don't see, and then how it works. And Achilles is quite nice to start on because it's quite superficial. It's quite easy to see the anatomy, but it's important not to be limited, and don't limit yourself to one joint. Go over the joints and muscles as well. Learn the basic principles and learn the anatomy, because you've got to know the anatomy to know what's normal and then what's abnormal, what's missing. but no, definitely a global overview, and then focus it down onto more specific things as you get more confident.
And just in terms of that, Ben, so how quickly, like before you'd even scanned or gone on one of your educational courses, I presume you'll have come across imaging and an ultrasound machine before. How quickly can you go from, say, looking at a machine without having any training to sort of get an idea of some of the images that you showed us before? Like, can you start to pick things up before even doing a course?
Yeah, probably to a degree. I mean, everyone's a bit different and people pick things up at different paces. I remember when I was an orthopedic SHO, they'd have ultrasound pictures up in the fracture clinic and they'd describe it as a snowstorm. But I often think of it as almost like the Matrix, where suddenly, if you do enough of them, you're looking at the screen and it suddenly makes sense, and you can't shortcut it. So you've just got to do your time and scan lots of patients, even observe and then try and scan yourself. First thing is to try and get a good image, good picture, which isn't easy. And it takes time and a lot of practice, but after a few weeks or months, you could maybe start to pick things up a bit, but it depends on your background and experience, how many you've seen, but there's no shortcut to experience.
Yeah, well, that leads nicely into the next question, which is when should an aspiring SEM doctor start utilizing ultrasound?
So I would say, in my experience, I did it in my penultimate year of training, and I thought that was quite a nice time. Don't jump into it too early, because it's a nice add-on, but it's not your bread and butter. Your bread and butter is history examination. This is just adding it on. This is a nice thing to have, and people will want to kind of go onto the shiny things and the exciting things, but I waited towards, and most of my colleagues did as well, towards the last couple of years. But you also need to do it when you're going to have access to an ultrasound, or to an ultrasound clinic, or a radiologist or sonographer who's going to help and support you as well. Because you can do the course, and then if you don't do it for a while, you see this with a lot of people, is that you de-skill very quickly, and then you're probably not a safe and competent sonographer practitioner. So looking at, when you're going to have access to a machine to be able to do it regularly and keep skills at a basic level and then work on them. So I think towards the end of your SEM training, if you like, depending on the path that you take.
Okay, thank you. So we've got one more question. So if anyone has got any on the Q&A, they want to get them in quick, as long as Dan takes to answer this next one. So Dan, you've experienced with using a number of different systems over a period of time. How often would you recommend someone to, say, upgrade or change their system? Like how much do the improvements to the machines, does that change a lot?
So it's important to have them serviced as per the manufacturer's recommendations, but they can last 10 years plus. If you've got a good machine, has a good resolution, still produces good images, is appropriately checked and serviced, there's no reason why you would need to wait any longer. You would need to jump into getting a new machine. If it works well, provides a good picture, it's absolutely fine. You're probably only going to be upgrading your resolution a bit and maybe some fancy features, but if it's a solid machine that produces a good, safe image, then that's absolutely fine. And they're expensive investments and acquisitions, so you have to think whether you really need it, whether you're going to get good value out of it.
Yeah, no, I think that's a really good point. And going back to what we discussed earlier on, I think not just understanding what the cost of the initial outlay is, but the life cycle cost of the machine. So not just the initial payment for it, but how long are you going to need to have it serviced and so on. So it's always worth asking that question of anyone who you're speaking with. So Dan, thank you very much. We've come to the end of the questions. Unless there's anything else that you want to share, I found that really, really helpful and interesting in terms of the practical applications of things. Is there any other closing message you think would be helpful for everyone?
No, I mean, I think it's very useful. Low risk to patients, but you've got to be aware of the limitations. And I think it's important to have proper training, proper sort of validated skills, and be aware of when not to use it or when you need to do further imaging. But it's a really good tool to have, and patients like it. They like to be able to see things quickly, get a quick answer. So in the sports medicine world, it's ideal.
Great. Thanks again, Dan. And I really appreciate everyone for giving up their evening to join us. So any questions, then please come onto our website, or we can put Dan's email in as well. And other than that, have a great evening and see you all soon. Thank you.
Cheers, everyone. Bye-bye.